Okay.
So hi, my name's Robin McNaughton. I'm a dietitian based within NHS Tayside, and my colleague here, Hazel Rogers, is with me today as well. So we're delighted to come along and have a chat to you today and discuss calculating MUST and developing nutrition care plans using the new MUST management guidelines. So I'm involved, as Ivan said, within a team around the prescribing of nutritional supplements. So some of you may be aware of the project that's going on at the moment across Tayside. It's looking at prescribing of nutritional supplement drinks in care homes, in the community, and also out in hospitals. So kind of the main aim is, for people to be prescribed the right nutritional drink at the right time by the right clinician. So hopefully we'll discuss that in more detail today. So the key messages, so by the end of the session today, we hope you will be able to know how to calculate MUST. So it might be a refresher for some, or it might be new to others. Know what to do when you calculate the MUST score. Know how to use NHS Tayside's MUST management guidelines, and that will be the new guidelines that we'll discuss in more detail. And feel confident about developing individualised nutrition care plans for residents. Okay. So undernutrition in care homes is much more common among care home residents than the general population. So just a few facts there from BAPN, the figures in 2015. So around 30% of residents within care homes were malnourished, compared to around 4% in the general population. So quite a big difference. Care home residents are also at risk of dehydration and its consequences of that. So looking to see who is at risk of malnutrition and dehydration. So quite a big list there of residents who could be at higher risk. This includes residents with chewing or swallowing difficulties. So they might be on some sort of kind of texture modified diet. Dental problems, so if their dentures don't fit correctly. If they've got a sore or a severe dry mouth as well. Residents with postural problems who need assistance with their eating and drinking. Nausea, vomiting, diarrhea all have a huge impact to someone's appetite and their eating and drinking. If residents in pain, or if they have an ongoing infection. Constipation has a huge impact and a knock-on effect again to someone's appetite. Depression, low mood, again, are those at risk, and degenerative disease, so motor neuron disease, Parkinson's, Huntington's, and also dementia as well. Yeah.
Can I just say, there's a couple of new people who've just joined us. You are on mute at the moment. That's June and Marion. Can you both see the screen and can you hear us okay? If you put your hands up so I can see you waving. That's fine. At the end, there'll be a chance for questions. We've only just started, so you've not missed very much at all. Okay? I shall hand you back to Robin.
Thank you. So I know you guys can hear me, but I can't quite hear you. We've got a question on the screen there asking which one is malnourished. So I guess it's just having a wee look to see, which one's maybe the obvious. Kind of thinking around the thoughts around which one of those sort of three pictures are malnourished. As we can see, the thin man who's on the left-hand side of my screen is very malnourished. He was actually part of a study in the wartime on the effects of starvation for 6 months, so that's quite clear. You can see his ribs. Taken to the other side of the picture, the man with the measuring tape, he's measuring his waist. Would you say that this man's malnourished? I guess the question is, it depends. Has he recently lost weight? In which case, even an obese person may be at risk of being malnourished. So it might not be an obvious case compared to the other gentleman, but it just shows that anyone can be at risk of malnutrition. Similarly, for the lady in the middle, her weight or her body mass index or her BMI looks to be within the healthy range. But again, if you're actually looking quite closely, you know, her clothes a bit baggy on her, or her wedding ring looks a bit loose. So potentially this lady could have lost quite a lot of weight within the last, you know, space of a few months. So again, that lady then would be at risk of malnutrition. So I think these pictures are quite clear at highlighting that it's not just the obvious residents or people who are at risk of malnutrition. So nutrition screening, as we've just kind of highlighted from the pictures previous, it's not always obvious who is at risk of becoming malnourished. And nutrition screening is a great way to help identify those at risk. So the MUST booklet, which I'm sure most of you will be familiar with, stands for the Malnutrition Universal Screening Tool. So it is a nationally validated tool used across the UK within care homes and also within hospitals. So it's the most commonly used tool to identify those at risk. So there is 5 steps of MUST in which we will go through in detail about how to calculate the different steps. I'm aware that step 3 for care homes had been previously removed, so it has been added back in to help kind of streamline and help with the scoring of MUST. So we will go through these all in much more detail as we go through you know, calculating the MUST scores. So starting off, how to measure weight. So for us working as dietitians, it's very important to get an up-to-date weight and also a reliable weight. So as it says on the screen, all scales should be on a flat, hard surface, which is very important to make sure that the you know, figure at the start is at 0 and the scales are on a hard surface. Taking into account items of clothing, you know, anything in pockets, heavy items of clothing, so baggy jumpers, shoes, full catheter bags, cushions, foot plates, you know, within wheelchairs. You know, it's about keeping things consistent. So all these sort of things need to be removed or taken into account when someone is being weighed. Ensure the resident isn't leaning on anything. So again, that can affect the person's you know, weight. If they're leaning on a surface or leaning on a you know, an assistant who's helping them get weighed, will again affect their weight. So make sure that it's they're kind of standing alone. And yeah, ensuring the scales are at 0 in the first instance. Place the resident on the scale and wait for the reading to stabilise. You're looking to record it to around the nearest 0.1 kilograms to get the most accurate weight. And also, you know, recording the date is really vital when you're documenting it.
Does the time of day matter?
The time of day, again, you're wanting to keep it quite consistent. So if, you know, each month, so if it's in the morning, again, you want to keep that thing consistent each time you get weighed. So typically, most care homes tend to do it at the weekend, not saying that's the right thing to do or not, but possibly, you know, if you're weighing every Saturday morning, for example, just trying to keep the variables consistent. So whether they've had breakfast or not, just keeping that consistent each month.
Okay.
Yeah. So the table here takes into account, you know, someone's dry weight and also their kind of water weight. So if someone has ascites or peripheral edema, it's important to take that into consideration. So for peripheral edema, it shows on the table there that minimal, you would need to take off 1 kilogram. So minimal edema would be around up to someone's ankles. Moderate edema would be up to someone's kind of knees, and severe would be up to their waist. So if that is the case, it's just taken into account to remove, you know, these numbers, which is an estimate. So it would be 1 kilogram for up to their ankles, 5 kilograms up to their knees, and also up to their waist, about 10 kilograms. For ascites, again, they are estimated. So you would be looking at getting the GP involved. It is using kind of clinical judgment, but thankfully you probably won't have a huge amount of residents, you know, with ascites. Just looking at the example there, so a patient has edema up to the knees. He weighs about 72 kilograms. So to estimate his dry weight, so looking at that table would be about moderate. So you're looking to take 5 kilograms off his weight for moderate peripheral edema. So his estimated dry weight would be about 67 kilograms. And it's that estimated dry weight that you need to use for the MUST calculations.
That's, yeah, I don't think I've seen that very much, that sort of calculation, so that's useful.
And if anyone was struggling or didn't quite understand it or couldn't find the table, what to do is just phone your local dietitian, and they'd be quite happy to help you work that out or work it out for you. These tables are within the BAPN, the online explanatory booklets. So if you are looking for the tables, they are on there, or you can get copies of the slides as well to put within your MUST management guidelines. But if in doubt, as I say, just phone your local dietitian and they would help work that out for you. Okay, so similarly, estimating weight following amputation. Again, I don't know how common it is. And again, if you were struggling with these sort of calculations, then do just phone your local dietitian and they would be able to calculate it for you. Basically, what you're doing for an amputation, you need to actually add that weight or estimated weight back in. So as it shows there, so for a full leg, what you're wanting to do is add 15.6% of their weight. You want to add that on. And
you couldn't have made that just 16%.
Yeah, it would make it easier. So yeah, 15.6 are quite specific percentages to add back on. We can run through the example shown. So a patient has had their full arm amputated and weighs 54 kilograms. So you want to correct that weight. So by looking up at the table, looking at what a full arm amputated, you're looking at 4.9%. So you want to add that weight to the weight that they're weighing at. So that's the 54. So to do that, what you could do is what I would do in this division would be 4.9 divided by 100, and then you would want to times that by the weight that you've recorded. So for this example, was 54. So that equals 2.6 kilograms. So that's basically the weight of that full arm that you want to add back in. So you would then add the 2.6 to the original weight of 54. So it would be 56.6 kilograms. So that would be the corrected weight. And you would need to use that corrected weight for the further MUST calculations.
And all of this will be recorded, so you don't have to work it out, try and remember all of this. You'll get all of these slides sent to you.
Yeah, I know it can be quite hard looking at all the numbers, but even if you had that table within the MUST, your MUST kind of guidelines and your booklet. But as I say, if you are in doubt, just do phone your local dietitian and they can work out the requirements or the added sort of weight back on. So it just shows you all the added weight within that table. I hope that makes sense.
Yep.
Yeah. Okay. So how to measure height? Ideally, using a height stick is the most ideal way to get an accurate height. Taking into account or remembering, you might not get a true, or you won't get a true reading if someone has a stooped or curved posture. What you're looking to do as well, using a height stick or even just a measuring tape. Most places will have a measuring tape that you can use, or most places will have for using other kind of clinical procedures. Making sure it's against the wall, removing the resident's shoes, and recording it, preferably in meters to 2 decimal places. If you've not got a height stick available, if you could try and look at GP records or even hospital records to see if there's been a height recorded. Most reception staffs within GP practices are really quite helpful, so they would be able to inform you of that information. Quite important as well is asking for the date of that height, because some heights recorded within GP practices could be 20, 30 years ago, and that then will not be quite accurate. So it's quite important because someone could have lost a bit of height over the years. So it's important to ask the date of that height. Or if you've not got access to those sort of records, ask the resident and their relatives for their height. Just bearing in mind, if you're asking the resident if they've got any sort of cognition issues or dementia, it's just bearing in mind those, or asking a relative. If the above was not available, then what you could use is an ulnar length, in which I'll go into in more detail just for the next 2 slides. Some people have used the demi-span before, which we don't actually use in practice anymore, because the ulnar length has been found to be more reliable. For learning disability residents, they can be measured lying down, or as advised by the learning disability dietitian.
Why does that apply to learning disability residents?
Just because learning disability residents, well, would you?
It's more for if they're not always able to cooperate with ulnar length being done. So measuring them and also standing up. So measuring them lying down is absolutely fine. If they can stand up, if they can have that ulnar length done.
But that would be for any resident, really.
Any resident, yeah, the same thing, yeah.
And remember to record what method you have used, whether it was your ulnar or reported or an actual height. So using the ulnar length, there is instructions or a table that you can use within the MUST explanatory booklet, which you can find online. But when to measure the ulnar is if you can't get access to someone's files, you know, if they're not able to tell you or inform you of their height, or if you're unable to get an actual height from them. So basically, what you would do is basically measure from the point of the elbow up to the most prominent part of your wrist bone, and you would measure that and then compare that with the table that's within the MUST explanatory booklet, and that has a table in which you would use that length, and that would give you an estimated height for men and women, and there's for over 65 and under 65. So I don't know if you can see that all right, but that's just an example of the table that you can find within the BAPN website for help explaining the ulnar length. Okay, so step 1 of MUST is to calculate your BMI, which is your body mass index. What your body mass index does, it basically tells you how healthy your weight is in relation to how tall you are. So first of all, you want to obtain an accurate height and weight. These are the 2 components needed to calculate your BMI. Again, within the MUST explanatory booklet online, which you can find on the BAPN website, there is a ready reckoner that can help you use or help you calculate the MUST score, which I'm just going to show you an example.
Don't worry.
Yeah, not to worry. There's tables that you can use, you know, to help work it out as a ready reckoner, or you can use the calculation. So to work out your BMI, you basically want your weight in kilograms, and you want your height in meters. So basically, what you do is you want to use your height squared. So that would be your height times your height in meters. And then you would do your weight divided by your height squared. I hope that makes sense. So to calculate your height squared, you would times, basically, for example, we'll use Edna. So her height is 1.64 meters. So basically what you would do to calculate the squared of that would be to times it by itself again. So that would be 1.64 meters times 1.64 meters. And that would then give you a figure, which I think is around 2.68. And you would then use that. And then what you would do from there is use your weight in kilograms divided by that figure, which is the 2.68. And that would then calculate your BMI score. So if we're looking at Edna, for example, her height is 1.64, and what we could do, and her weight, sorry, is 40 kilograms. So what we're doing is 40 kilograms divided by her height squared, and that would give you around 14.87, and then you would round it up to 15. So her MUST score, so her BMI there would be 15, and that would then give her a MUST score of 2. So you might have seen this chart before. So this is quite a helpful way of calculating the MUST score without having to do that calculation, because if you're not used to using sort of maths and doing that calculation, it can be quite tricky. So this chart is quite useful for just a kind of quick go-to. So as I say, this is in most MUST management guidelines, and also can be found on the website. So basically you've got your height in meters along the bottom, and you've also got your height in feet and inches along the top. And then you've got your weight in kilograms along this side, and then you've got your weight in stones and pounds along this side. So depending on what kind of values you prefer using, you can then work out. So for example, Edna, her height was 1.64 meters, so that's around here, and her weight is 40 kilograms. So you then go up to the 40 kilograms and then kind of find out where it would meet in the middle, and then that would tell you where your scoring would be. So that red range would be a score 2. So that would put Edna at high risk of malnutrition. Okay, I hope that makes sense. It's not very clear because you can't see the figures, but you'd be able to see the chart online. And then for Arthur, his height of 1.7 meters, weight 65 kilograms, that would give him a BMI of 22 and a MUST score then of 0. So within that chart, he would be at low risk of score 0. Okay. Okay, so step 2 of the MUST management guidelines is the weight loss score. And again, there is another chart that you can use as a ready reckoner for calculating it, which again is on the website. So basically, what you're looking to do is get the most up-to-date weight, and you're then looking at, so basically what you need is a weight history. So you're looking to get the most up-to-date weight and then a weight around 3 to 6 months ago to calculate that weight loss. So you don't want to use just the previous weight, which could have been the previous month, because that's not giving an accurate representation of the weight loss. We're looking to get that 3 to 6 month figure. So MUST score of 2. So if that resident has lost over 10% of their body weight within that time period, they would then score a MUST score of 2, which would be high risk, and that would be clinically significant. If the resident has scored or lost between 5 to 10% of their body weight, that would score a risk score of 1, and that would not be as serious, but unless rapid and already malnourished. So it's not as clinically significant, but it is still medium risk. And then if it's under 5% within that 3 to 6 months period, they would score a score of 0, which would not be significant.
What's your view of someone who's just come into the home and they've been with you for less than 3 months? If they were losing that, say over 1 month, they've just been admitted, would people get in touch with yourselves to refer them? Because if they've just come in from, say, hospital and they've lost that sort of figure of weight, because you're not going to say wait 3 months, you'd want to know that straight away, I take it.
Yeah, so if you've not got weights within the home, if they've got weights within their within their hospital records that can be passed on. But yeah, if there was any concerns,
we don't get anything passed on by the
right,
hospital.
okay.
Let's be honest.
Yeah. If there was any concerns, we would just advise just phoning the dietitian and speaking to them, and then they could advise, and then I would put a referral in if it was discussing with the dietitian.
That's fine.
Yeah. Okay, so step 3 of the MUST, I hope everyone's following it so far. So step 3 of MUST is the acute disease effects score. This has been added back in for care homes because it was previously removed. This basically applies to patients who have had or are likely to have no nutritional intake for more than 5 days. So this would be, for example, residents or people with dysphagia, so kind of swallowing problems, and if they're on a texture modified diet, intestinal obstruction, unconsciousness, a head injury, or a critical injury. So these patients are mainly in acute hospitals, so often not applicable in the community. So probably very unlikely for care home residents to score within the step 3 of the MUST. But it's just being aware that that there is a step 3 there. You would never either as well score a 1. It would either be a score 2 if acute disease effect applies, or it would be a score 0. So there would never be an option for a 1 within that step. Okay. Just following on with step 3, so the acute disease effect score. If death is imminent, it's not appropriate to score step 3 or refer to the dietitian. There is also new palliative care guidelines uploaded onto our Tayside Nutrition website. So there is updated guidelines on palliative care. If a patient is being fed their full nutritional requirements via the enteral route, so if they've got a nasogastric tube in place, this is considered their oral intake. So therefore it's not appropriate to score at step 3. And they're also very likely to be known to the dietitian already as part of their care. And just looking at any sort of underlying conditions as well is really important, and you are wanting to treat these. So is there a reason to why they're not managing their intake? If they've got ongoing issues with nausea, vomiting, pain, these are all sort of things that you want to look at as part of their nutritional care planning, and treat any sort of underlying conditions that are going on that could affect their appetite or their intake. So step 4 of MUST is the overall risk of malnutrition. So this step is basically adding up all the scores from step 1, 2 and 3 and documenting that. So a score of 0, so a score at 0 at all them stages would be a low risk. If they scored 1 at any of them points, they would be at medium risk of malnutrition. And if they've scored 2 or more at all them 3 stages, their risk would be at high. So it's important just to document that score at step 4. And basically step 5 is then the MUST management guidelines. So it's basically what do you do next, and it's about then following them guidelines. So the MUST score is calculated, and then we'll kind of go through and chat more about the new NHS Tayside MUST management guidelines. So it's about kind of the next steps and care planning. This is just a bit of a screenshot of the proposed new MUST management guidelines that we're working on at the moment. So I know you won't be able to read that in a huge amount of details, and it does kind of have draft written on it at the moment, but it's just to kind of highlight and just to make you aware of the new MUST management guidelines for Tayside. So we'll go into these in a bit more detail as we go through the guidelines. And
how will we get that? Will be sent out to all the care homes, will it, when it's ready?
Yeah,
that will be sent out.
Yeah, at the moment it's still in draft. So once we finalise this, it will be sent out to all care homes.
Okay.
Yeah, and you can put it in the MUST management folder that you've got for staff to look at. Okay, so as part of the new MUST management guidelines, basically it's quite similar to as before for the likes of MUST of 0 to 1, which would be care home based nutrition. So as we said, MUST of 0 is low risk, and MUST of 1 would be, 0 is low risk and 1 is medium risk. unless there's another indication for dietetic referral. So it's not just solely reliant on must scores for a dietetic referral. And then must of 2 or more, we were then asking for you to refer to the dietitian. So irrespective of must, you'll see there all the different other indications for a dietetic referral. So if someone's got enteral nutrition, so if they're fed via a tube, in which there should be a dietitian involved already, that would indicate for a referral. Patients on a certain modified diet, for those who have swallowing problems or chewing problems, so the likes of texture modified diets that aren't nutritionally complete, or esophageal stents. Anyone with a newly diagnosed inflammatory bowel disease, so that would include Crohn's or ulcerative colitis. Newly diagnosed celiac disease, medically diagnosed food intolerance, or for renal patients requiring any sort of low phosphate or low potassium diets. So these are all other indications for dietetic referral, irrespective of the must score. Okay, so just going into a bit more detail about the must management guidelines. So for a must score of 0, which is routine clinical care, we're asking you to continue to offer meals and drinks of the resident's choice, ensure the resident is well hydrated. What we're asking for there is to aim for 30 to 35 mils per kilogram of body weight. So to help you kind of calculate their fluid requirements. So basically for anyone within the home, that's what you're aiming towards. And to repeat weight and must score monthly. So monthly weights and repeating the must score as well. But again, always when you're recalculating the must, just always bear in mind what you've used to calculate the initial. So if you've used their up-to-date weight and a previous 3-month weight, you're looking to keep that then consistent. So when you've recalculated the weight a month later, you're still wanting to use a 3-month ago weight to recalculate their must score. So I hope that makes sense. So you're not wanting to use the weight from the previous month. Always use and keep it consistent, so the 3-month ago weight. Or if you've used initially the 6-month ago weight, then just make sure when you're recalculating it, you're using a 6-month ago weight again. And consider the use of weight charts. They're really quite helpful, and they're a good visual to see the trends of someone's weight, so if it's going up or down or if it's keeping consistent. And it can help you kind of keep track of what you're doing in the home. So, if you've been offering, more milkshakes, or, there's more fortifying going on, or, the family have visited more that month, different things can all affect someone's weight. So a weight chart can be quite good to help identify, what's going on in that person's life, or, if they've got an infection, their weight might drop a little bit, just if they've lost a bit of their appetite. So a weight chart can really be a good visual. So a must score of 1, so we'll kind of class that to observe and identify sort of any risks affecting the residents' ability to eat and drink and take action if required. So as we've kind of discussed already, identifying the factors which could affect someone's intake. So if they've got chewing or swallowing difficulties, whether a referral to a speech and language therapist is inappropriate at that point, so they can come out and assess someone's swallow, and they may need to then go on texture modified diets. If they've got any sort of dental problems, if there has been significant weight loss, their dentures might not be fitting, so it's just about kind of checking any of these sort of things and taking action. For someone with postural problems that require support with their eating and drinking, just making sure that these sort of residents are getting supported. Physical symptoms, so as we've discussed, infection, pain, vomiting, diarrhea, constipation, all have a huge impact to someone's appetite and their intake. So about monitoring these sort of things and treating for these sort of things to be overcome, and hopefully then we'll have a knock-on effect and improve their appetite if these sort of things are identified and treated. Also sort of pressure ulcers, severe dry mouth and disease progression, to take these sort of things into account as well. Other factors, mental health issues or challenging behaviour, and any impact on of treatment or medications. So again, these sort of things can have an effect on someone's on their intake. So just bearing in mind all these sort of things. Okay. So just continued. So to agree an individualised nutrition care plan with the resident, in which we will go into in a bit more detail as well. So it's about really trying to, identify and come up with individualised care plans that are really person-centred care, and sharing this with all staff, including the cook. So about getting everyone involved with that person's care plan. For a must of 1, repeat weight weekly and complete the weight monitoring chart again. We're wanting then you to repeat the must after 1 month. So must doesn't need to be done weekly, weight weekly, but the must score, again, you would just calculate that monthly. If improving, continue until low risk. So, if what you're putting in place for that nutrition care plan, if their weight is coming up, then great. Continue that until they're within the low risk range. If deteriorating, consider treating then as high risk. And if you were concerned about any sort of residents, do give your local dietitian a call, and you can discuss that further with them. And then it's possibly appropriate to put a referral in for those. But we would advise speaking to your local dietitian. Also, just in relation to kind of care planning, what we'd ask you to consider and document is the aim of nutritional intervention. So, kind of what are you looking at, and what you're looking at to, aiming against. So, are you trying to promote? Are you looking to promote weight gain back to a healthy BMI range? Are you looking to maintain their current weight or their nutritional status, depending on kind of what else is going on? You want to optimise nutritional intake during a period of illness, if it's just a short term, while they're not well, or if you're wanting to increase or promote adequate fluid intake. So I guess just kind of looking at all kind of factors that are going on and having an aim as into what you're looking to kind of plan and promote. Okay. So must score of 2 or more. Again, would be a high risk. So what we're asking you to do here is complete all actions for a must score of 1. If actions are not successful in meeting their nutritional aims after 1 month, we're asking you then to refer to the dietitian, in which we'll go into in more detail later on. If a food first approach is not successful, in which there has been a different webinar on food first, which goes into that in a lot more detail, and we will touch on that again when we go into a bit more about care planning. If that has not been successful, you can consider trialling a first-line powdered nutritional supplement drink, and what we're asking is to offer 1 sachet per day, preferably made with 200 ml of full-fat milk, until they're assessed by the dietitian. So after referral, if all sort of food first approaches have not been successful, then you can consider then trialling a first line powdered. There is a lot of different companies that do a first line sort of powdered nutritional supplement. I'm sure there's lots of residents on probably lots of different products. There's Complan Shake, there's AIM Shake, there's Ensure Shake. There's lots of different products out there. So we're still kind of in the middle of kind of figuring out which one will be the first line for care homes. But at the end of the day, it doesn't matter too much which powdered it will be. They're all very similar, in which most of them are made with 200 ml of the full fat milk. So that will be for those with a must score of 2 or more only. So it's quite important. Okay. So with the powdered nutritional supplement, it is a high energy nutritional drink. As I say, mixed with 200 ml of full fat milk, provides good amounts of calories and protein to help towards the aims and their nutritional intervention really. These powdered drinks, most of them can be made up with fresh fruit juice as well, or also fizzy drinks. So it's worth trialing these sort of things as well if someone really doesn't like sort of milky drinks. but that can also all be discussed with the dietitian. But it's just good to bear these sort of things in mind, and be a bit creative with them as well. So they don't just need to be added to milk. You can add a bit extra to add a bit more extra calories into them. But again, these sort of things can be discussed with your dietitian. And they can't be used as a compact supplement. So most of the companies say to make it up with the 200 mils of the full fat milk. If a resident does struggle with volume, you can offer this drink at, as a dosed, so maybe 100 mils and then 100 mils later on. We would never promote these sort of drinks directly before a meal. So we'd always advise to offer these sort of things after a meal or also in between, because it can have quite a knock-on effect to someone's appetite if it's quite small in the first instance. Most powdered drinks last around 24 hours. So once they've been made up, as long as they're kept refrigerated, and they do come in a variety of different flavours. Most of them are on the sweeter side, so they tend to be kind of strawberry, banana, chocolate, and a vanilla. And some companies also do a kind of neutral or original flavour as well, which has no flavour. And some also have recipe booklets. So these sort of things are great to find out what else you can do with them, rather than just solely being a milkshake drink. You can do a lot more and add a bit more as well, be a bit creative and add fruit and make it into more of a kind of smoothie style drink. As I say, the fizzy drinks are another great one, but again, just bear in mind if someone's got diabetes, these sort of things can be discussed with the dietitian. I've certainly tried a powdered drink with Iron Brew with the vanilla flavour, so yeah, they are nice. So yeah, these sort of discussions can be can be in joint with the dietitian if it's appropriate for the resident. Okay, so just a little bit around nutrition care planning. So when agreeing an individualised nutrition care plan with the resident and family, it's really important to get everyone involved with the planning of that. And once you do have that, it's really important to share with all staff, including the cook. So a care plan may include a variety of things, which I can go through, and there is an example on the screen there of quite a generic example of a nutrition care plan, and an example of something that is a bit more person-centred, so a lot more individualised, which is what we're really trying to promote. So what we're trying to say is we don't want just generic ones that are maybe just kind of standard, fortified diet, extra snacks, milky drinks, weekly weights. That doesn't really tell you much about the resident, doesn't really go into much detail at all, whereas comparing that to a person-centred nutrition care plan, adding half a cup of fortified milk and 2 teaspoons of honey to their porridge tells you a lot more about that resident. That's what they like, and it's very specific. It's what we're aiming for. Offering a digestive biscuit spread with butter and jam with each of their cups of tea. Again, that's much more person specific, and it's much more person centred. This resident likes a glass of milk and a chocolate biscuit while watching Countdown. It's very specific, and that helps staff, if staff are coming and going, to know exactly what that resident likes. Yeah.
You can see a real difference between the two. Yeah. Absolutely.
So kind of goes into a lot more detail. So that's really what we're looking at, is much more individualised care plans. Prefers windows. So it's not just about the fortified diets around, the food first approach is much wider than that. So looking at the environment, looking at kind of who's there, and what that resident likes, meal wise, but also do they like sitting at the dining room, what company they like, looking at kind of a much wider picture. So much more about the environment as well.
Okay.
Okay, so when to refer to a dietitian? So after following the must management guidelines, if they've got a must score of 2 or more, we're looking for you to refer to the dietitian. But again, it's not solely on must. So as we've discussed already, there is other indications, which we've just highlighted then at the bottom as well. So immediate referral is specific nutritional concerns, so other sort of concerns, so cancer treatment causing taste changes, any sort of renal problems, swollen problems, any sort of newly diagnosed inflammatory bowel disease, celiac, which we've discussed already. So these are sort of regardless of must. So that could be indication for a dietetic referral as well. So how to refer? So at the moment, we are looking to use the standard dietetic care home referral form, which might change in due course, moving as part of this piece of work. It may move more to a web-based referral system, but for the moment we are still looking to use a paper-based referral at the moment. So yeah, the dietetic care home referral, which is found again on our website, which is the Tayside Nutrition website. No need to request referral via GP. It actually takes longer, so it will delay the process. So you're better just referring straight to the dietitian via that form. And the food record charts are still getting filled in. So yeah, as much detail as you can around food record charts just helps the dietitian get a good idea and a good picture of what that resident's managing. So that would include all their meals, whether it was half, if they manage the full portion, half or a quarter, would include all sort of snacks and all sort of fluids as well. So nutritional fluids are really important. So if they're having lots of cups of tea, if they're having a glass of milk, orange juice, all these sort of things should be recorded as well, and the quantities consumed.
One question on referral: can anybody refer? It doesn't have to be a nurse.
Doesn't need to be a nurse. Okay. Anyone can refer.
Yeah. Okay, that's fine.
Yep. And just a slide there on highlighting the resources that we've got within the Tayside Nutrition Network. So that's our website, and there is a section under within that for care homes, which have a huge amount of advice and information and resources, and other really useful links that you can access. So it is a really helpful website to go onto. What I would say is when you type into Google, you could just type in Tayside Nutrition Network and it just comes up with the first link. Do advise doing it on Google and not Bing. For some reason it doesn't work with Bing. So yeah, lots of good resources which you can access, but just these are some examples. So there's 100 calorie boosters, a guide to finger foods, nourishing snacks and drinks, and problems affecting nutritional status. So they're really, really good resources, and a lot of kind of recipes for milkshakes and smoothies that you can access to, and sort of fortified milk as well. So I can show you some examples of them.
That's really good. We've had a look at that here and found it quite useful. We've referred to that website a couple of times recently.
Okay.
Once we found it,
yeah.
We use Bing.
It works for Google, but for some reason Bing doesn't get access. Yeah, so Google and they just type in Tayside Nutrition Network.
I didn't know that before.
Oh well, good to highlight. So thank you for listening, and is there any questions? And we're just going to go probably back to a few things as well, but we can answer questions in the meantime.
I'm going to unmute you all so you can all now ask any questions. Has anyone got any questions?
Hello?
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 What's your question?
It's Leanne. I'm just wondering, when you're referring, would you want a copy of the person-centred plan to see what kind of things have been working, what's not been working?
Yeah, if you're able to send the nutrition care plan and what you've tried already, that would be great. Yeah, that would help the dietitian just identify and figure out, what's been tried and what's worked and what's not worked. So as much detail as you can, that would be great. Yeah.
Okay.
Any other questions from anybody? That'll be a no then.
No.
Okay, well, what I'm going to do then, I'm going to stop the recording and then just ask you an evaluation. Oh, Robin's got one more thing.
Yeah, it was more just to highlight, as part of this kind of big piece of work that we are doing, there is sort of new national guidance out around the prescribing of nutritional supplements, at a Scotland-wide level. So as part of this piece of work, we're really trying to adhere to these sort of guidelines that are being put out. So that's the kind of reasons behind this kind of piece of work, and that with as part of these guidelines, they are highlighting that anyone who's on a sort of nutritional supplement drink should be under the care of a dietitian, and that it is for those with a must score of 2 or more. So it's just to kind of highlight that.
And the session later in the week will go over the changes to the nutrition supplement, which Robin has referred to, and how we all go about ordering and how we contact dietitians. That will be in the next session from the lead dietitian.
Yeah. So as well, there is a food first one that we've done already.
Yeah,
so
yeah,
this one was
well.
more must, and then there will be another one around the process of this. So thank you for listening.
I'm just going to stop the recording and then I will ask you for an evaluation. Hang on a second. Don't leave me yet.